Good afternoon. I want to thank you all for coming, making it through the rain today to this California Healthcare Foundation sponsored briefing on all payer claims databases, what we've learned from other states, and what we're looking at here in California. So first I want to mention a little bit about the California Healthcare Foundation for those of you who might not be familiar. And we have people here in the room. We also have a number of registrants for the webinar, so we're hearing this through the web. We have 150 people or so who've registered on the web. So what I'd like to do is talk a little bit about the foundation and the work that we do in 3 primary areas, the first of which is better chronic disease care, where we try and help providers have tools so they can deliver better care. Innovations for the underserved, where we're focusing on innovations that might help spread access to health care to populations that otherwise may not get that. And in particular, wanted to draw attention to a new CHCF Innovation Fund that we've developed, where we can actually invest in companies that are developing innovations. And then the third program area is the Market and Policy Monitor Program, which is the one that I lead and the focus of this topic today on all payer claims databases. And there we're trying to encourage accountability and transparency in California's healthcare markets. And the foundation also has an initiative, Health Reform and Public Programs, which we've developed because really of the timeliness and the questions that are coming up about health reform and how that's going to affect California. So let me talk a little bit about this particular project and why we're interested. So as I mentioned, we're very concerned about accountability and transparency, and particularly as healthcare costs continue to increase, understanding utilization patterns and costs of care we think is going to be really important to trying to come up with effective solutions. As we look at things like accountable care organizations that might come about through health reform, understanding how healthcare costs are developing here now before those innovations come in, and then being able to track them afterward, we think is really important. So a number of states have already jumped into the all-payer claims database space and have started developing these resources. And so today we have Patrick Miller, who is from the University of New Hampshire and is also the co-founder of the All-Payer Claims Database Council, which is a national organization that collects resources for states to use as they develop all-payer claims database resources. And then we also have Jonah Froelich. Jonah Froelich is with Manat Health Solutions, but many of you may remember him from a recent role as the Deputy Secretary for Health Information Technology here for the state of California. And prior to that, Jonah was a colleague of mine at the California Healthcare Foundation. So I wanted to remind you that we have some evaluation forms that are bright green that we'll ask those in the room to complete before you leave today. And we'll have a question and answer session after our 2 speakers have finished, and we really encourage you to raise any questions that you may have. We'd like to be able to answer questions about this project and really other things the foundation's involved in if you have questions about those as well. So with that, let me turn it over to Patrick Miller from the University of New Hampshire. Patrick.
Great. Thank you very much, Mary Beth, and to the Foundation for the invitation to be here today, and for folks on the web and in the audience. My name is Patrick Miller. I'm with the University of New Hampshire and the All-Payer Claims Database Council, which is a partnership between the National Association of Health Data Organizations, which has been around for about 25 years, and a consortium of states and payers and other organizations, and I'll talk a bit about that as we go through. My main goals today are really to talk a little bit about what all-payer claims databases are for those that are not familiar with the terminology, talk a bit about the resources that are available, give you some usage examples so you can actually see what states have been doing with these databases, and then at the end, a bit of lessons learned and challenges. So just jumping into it, first place, a point of stop, I guess, if you will, on the chain, we believe is the APCD Council if you're looking for resources. We have multiple white papers that are geared towards policymakers and other folks within the healthcare industry that have been sponsored by the state coverage initiatives and AHRQ, as well as the Commonwealth Foundation. And essentially, the website, state by state, you can find out who's running the database in that particular state, what resources they've made available, what data they're collecting, how long they've been around. Essentially, it's sort of a one-stop shop. In terms of some of the activities that we're involved with nationally, one of the major focuses that we have is on the development of data collection standards so that each state will ideally in the future be collecting exactly the same information. And I'll talk later on about why that's important. We're providing direct technical assistance to states. We do a lot of APCD 101 type of presentations. We go out to states. We help states work on legislation, provide advice as to what other states are doing, and connect states with other states. That's a large part of our role. We don't have all the answers, but most of the states that have been through this do, so we can connect them. As I mentioned before, publications, issue briefs, there's an annual conference, and a wide variety of partners. It's sort of like being at the Academy Awards, where if you put a list like this up, you're going to leave somebody off. But we right now have participants from individual states, carriers, federal agencies such as AHRQ, AHIP representing the health plans, NCPDP on the prescription drug side, Commonwealth Fund, and National Government Association, and Academy Health. And these folks have all participated on a voluntary basis, some also on a monetary basis to help move this forward across the country. We've also assembled a technical advisory panel, and again, this is a long slide full of acronyms, but it's, I think, important in the sense that this group was called together last year to start to tackle the issue of national standards and how states can start to work together in a way, in a more formalized fashion, and also to start to involve some of the federal agencies in this. So you'll see here CMS and AHRQ and ASPE and others that are involved. And again, I won't go through all of them one by one, but this group meets about monthly at this point in time and is helping us, again, primarily on the standards work. In terms of the backdrop, just in the last 6 years, a lot has certainly changed in the landscape. And as Mary Beth mentioned, first and foremost, an increased effort on transparency has really been driving the development of these databases in the states. And I'll talk in a moment about which states are doing what. We've also had, in many states, employer coalitions, and I know there's large ones here in this state, who want more transparency for their own members. And then obviously overall payment reform and how can these databases be useful in patient-centered medical home programs, accountable care organizations, and other things that are coming down the pike. We've also seen, as Jonah well knows, high-tech and the HIT and HIE incentives, and how these databases in the future are going to be able to interact with things like health information exchanges and health benefit exchanges is also on the radar screen, and everything that's coming out of the health reform bill. So just since some of these early efforts got started, a lot has happened nationally, which again, we're providing essentially these databases as tools to help support many of these efforts. So in terms of what a definition of an all-payer claims database is, the definition that we've decided on at the moment is that they are databases that are created by state mandate, and I'll talk about that because it's a little controversial, that typically includes data coming from multiple sources. So we have medical claims, we have pharmacy claims, eligibility files, provider files, and dental claims. And we're getting it across carriers, both on the private side, so third-party administrators, PBMs, medical and dental, as well as public payers such as Medicare and Medicaid. And so all this information is being aggregated into a single database. This is just a visual diagram showing the different data sources and sort of where folks typically start from an implementation perspective. The outer ring represents the commercial information. So this would be your HMOs, your PPOs, your third-party administrators, dental, Part C and D, and Medicare that are processed by the carriers. The next ring in is really a state function in terms of Medicaid, so looking at your fee-for-service, managed care, and SCHIP population. populations. And then we get to Medicare Parts A and B. Only about 4 of the 12 states that are currently moved forward have Medicare data, but more are seeking to integrate that as we move forward. And then ultimately, there's other populations as well, such as at the federal level, TRICARE and the Federal Employee Health Benefits Program. And then there's the uninsured, which is a problem because they don't generate claims. And the only example we have right now of a state that actually is collecting uninsured data is in the state of Maine. They issue ID cards through a program to uninsured, and a local carrier processes them just as if they were an insured patient. And so we believe about 40% of Maine's uninsured population is being captured in their database, but there's no other way at this point in time that's been developed to capture uninsured. So unlike your discharge databases that OSHPD has created where you have uninsured data, we do not have it in these databases. So what are these all about? Transparency has been mentioned several times since we started this presentation. These are just some of the questions that have been answered by all payer claims databases. Things in terms of, geographic questions. So what does public health look like? Are we actually meeting our goals in certain geographies? As an employer, I can look at things in terms of things like preventive services, mammography rates, emergency room usage in Medicaid compared to commercial populations, what might be driving that, issues around medications, et cetera. And I'll show you some very specific screenshots in a few moments. But these are, again, sort of starting point questions. And literally hundreds of questions have already been asked and answered by these databases across the country. So speaking of across the country, the map that you see, which changes about every 2 weeks in terms of getting updated, the darker the color, the further along people are. So for those who can't see this incredibly well, the dark blue states are existing operational platforms that have been moved forward. Oregon and Colorado and Rhode Island are the next tier down, and they're in the middle of their implementation process as we speak. And then we have California's color, which we call strong interest, which could be anything from we've spoken to members of the legislature to legislation has actually been filed. And in fact, West Virginia is in that category, and it needs to change. As of 2 weeks ago, their legislature passed a bill, and we're now waiting for governor's signature there. So there are, essentially lots of interest. Texas has also filed a bill in this session, which would create a study committee to provide recommendations on how to move forward. Iowa also has introduced legislation. We have 2 states, Washington and Wisconsin. If you remember in the definition slide created by state mandate, these are 2 states that have voluntary efforts. They're created, one's an employer-based effort and one is more of a private-based effort, where they are taking data on a voluntary basis, not across the full spectrum that we described in the bubble diagram, but it's important to note that these other models do exist as California moves forward in its process. So in terms of usage, this is kind of the fun part. When we first started developing these databases, or I should say states, I think the initial uses were really around how policymakers would have access to this information, how academics and researchers would be using this information. But what we've seen over time is that it's broadened dramatically just in the last 5 years. We now have consumer applications, we have employer coalitions, health plans and providers are also using the data. We believe ultimately the federal government will be using this in some way, shape, or form, and there's a database project that they're working on as well. So as an example, this is data looking at prevalence of asthma by age for New Hampshire Medicaid, going to my home state, and you can see the blue bars at the higher percentage rates are Medicaid, and the gray bars are commercial. And so we can use this to tie back to our public health efforts in the state, and we can also look at this by geography. And as we're taking a look at limited public health dollars and funding around asthma prevention and work in that area, we can use data from this database to help drive where those dollars should be spent. This is an example where the state of Maine used something called episode treatment groups, which essentially takes procedures and lumps all the services around that procedure together. This is a benign conditions of the uterus example, and then provides different scenarios based upon whether you're a surgical intervention, sort of a lower surgical intervention, or without surgery. And you can look at the cost ranges from about $11,000 to $1,200, depending upon how you approach the specific condition. And you can also take a look at things like the percentage of services that had a CAT scan or an ultrasound or other things attached to it. And this can be used very broadly at a state level. It could also be used by a health system that might be looking in terms of quality improvement and efficiency improvement. So there's lots of different ways that these methodologies are applied. And health plans have been using ETGs for a long time, as have many coalition groups on the employer side. Speaking of employers, we're finding increasing interest from employer coalitions for this data. This is an example of a coalition in the Northeast that's also benchmarking itself against a neighboring state. And this slide shows preventive services, mammographies, prostate cancer screens, et cetera. And this happens to be an employer who is taking this data and then combining it with its own health promotion programs for employee health and wellness. And it's actually a public employer. So if you think about the public employer sector, many times the employees are there for life and beyond with pensions, et cetera. And so there's huge incentive to really promote health promotion in these populations. And so we're finding in the public sector especially that they're using this data as part of their health promotion strategies. We've also seen examples in our Medicaid program for payment benchmarking. I've been told by numerous folks in California that you have the lowest Medicaid reimbursement in the country. We're probably 49 if you're 50, but nonetheless, our Medicaid folks have been using this tool set to understand how other payers are reimbursing for services and to use it for adjusting their own payment methodologies. This is actually a consumer-based screenshot from a product called Health Cost, where consumers that are commercially insured can indicate which insurer they have, which product they have, if they have a deductible, and then they can pick a procedure. This happens to be an arthroscopic knee procedure, and it shows them who's doing that procedure within the geographic area that they're interested in, and basically what the estimates of cost are in terms of what they would pay, what the carrier would pay, and what the total cost amount is. And for states like ours, where we have about a 70% differential in pricing in our provider marketplace and an increasingly high deductible insurance percentage of products being sold, these types of tools for consumers, we believe, are going to be taking on more importance as time goes on. And again, you can see here $3,200 versus $7,800, depending upon where you have the service done. And this is an example, similarly, out of Massachusetts, looking at a particular procedure, cardiac valve surgery, and it tells you, again, where it can be done and information in terms of the median value, the state median, and what that particular facility is. Neither one of these particular examples have quality combined with cost, and that's an important thing to talk about. And I'll talk about an example in a minute where one state has done that. We've also used it combining it with data from other data sources. So this is all payer data plus discharge data and for the state of New Hampshire. And again, I mentioned that 70% differential from the lowest hospital on the left side to the highest on the right. And what the insurance department has done is they've actually created a tiering program. So there's a tier 1 and tier 2, and all carriers are required now to sell a product in the small group marketplace based upon this data that is a tiered product. So there's tiered copays and coinsurances based upon this data that's been generated. This data is also being used by an employer coalition to help provide information to employees within that coalition as to cost-based information. And this is an example of that. Instead of an actual dollar, you see a $1, $2, or $3 sign on the right. This also combines quality information using leapfrog measures as well as CMS measures and patient satisfaction survey information. And so this was the first scorecard that was rolled out in our state, again, combining multiple data sources. Something else that our state has done has created a public website with access to chronic disease information, utilization and cost information, enrollment and eligibility, and then a whole series of child health care reports. It lives within our Medicaid agency and allows you to run reports, anybody in the world of the web browser, that can compare Medicaid information with commercial population information. And again, it's designed for researchers, for policymakers, and for other interested parties, has geographic querying, capacity, et cetera, attached to it. I won't show you any examples of reports, but the data goes from 2005 to 2010, and it's been a very useful tool. There's about 100 different reports that are available. So our state has a very public release policy attached to it to make data available to a wide variety of audiences. This was done as part of our health information exchange efforts in the state, looking at patient migration. The left-hand side are inpatient services and the right are outpatient, and the darker the color means more people are leaving that community to go somewhere else for services. And the reason we did this is that we were trying to make the business case that if you move for care, your data should move and should follow you as well, and that in HIE planning efforts, we could use this information to show which communities should be talking to each other first as connections started to get made. And we can now have the ability to do this type of analysis across Maine, New Hampshire, and Vermont with our databases. And we do have a lot of bleed across states in terms of this. And southern New Hampshire is effectively, for those of you who have been there, a suburb of Boston, so a lot of care heads south. This is very new data as of last Friday, and I just want to show it as something to come. There'll be a larger report later this year, but we've had a medical home pilot program with 9 sites running for 19 months where carriers have paid an additional PMPM to accredited NCQA level 3 medical home sites. And what we're starting to do is to take a look at the total per member per month amount of cost within these sites, both before and after. This is actually excluding pharmacy data and is not risk adjusted, and we're looking at just total cost from July 09 to March 2010, and we'll have, when there's 4 commercial payers in the pilot. But this was one of the goals that we had, was that this tool, the APCD, could be used to help us with some of the analysis work in health reform. We're also using it in an accountable care organization pilot to help set budget targets. Very difficult slide to read, and you don't need to read it, but what I'd like to just point out, this is from Vermont, and it's a series of rates, adjusted rates per thousand of different utilization measures, which are the big circle on the left, and the small circle on the right shows New Hampshire and Maine rates. And I point this out because we're now at a point, because we've been able to standardize our data across these 3 small northern New England states, to be able to actually compare information across states. Oregon, to the north of you, is developing a database. Utah has a database. Other states around you will eventually have databases. So if you want to start looking at cross-border and other issues, having standardization is important. This is another example looking at variation in health services, MRIs in particular. And this is rates per thousand by geographic area, with the darker having higher rates and the lighter areas having lower rates. And so, again, this is just a snapshot from one report that's been generated. So these are just some examples of some of the things that are being done with data. Other examples include risk grouping. The folks in Utah have been starting to do a fair amount of work with pharmacy data, which we think is going to be very interesting given the percentage of spend on medical trend on pharmacy, et cetera. So to kind of move towards the finish here, some of the things that we've learned. One is that there is a standard, if you will, kind of roadmap process that seems to be emerging, and I'm not going to go through it in detail, but it starts with some form of engagement process, a champion, and a very broad base of stakeholders, which is incredibly important, and then development of the governance model, the funding model, the technical build, and ultimately the analysis and development of these applications that I've just shown you. And obviously there are interactions between these 5 boxes. It's not as linear as the diagram depicts, but we have learned a lot in other states, and we have examples of what those states have done. All legislation, all the rules have been cataloged, et cetera, and are readily available to states like California who may be pursuing these activities. One of the biggest lessons learned across states is talk to your payers as early on as possible, because they are the ones who are providing the data. We've worked really hard with the large nationals as well as AHIP and others, and some states have done better than others, to be perfectly honest. Tennessee, I think, has really hit it out of the park by their process, and it was very transparent. Transparency itself around your process as you're implementing, we've also found has been key. And also post-process. We have states whereby you can literally go onto a website and see real-time what data for that particular month in terms of number of records was updated, which payers failed to submit that month, which payers did submit that month, that type of information. So there's a transparency around process, not transparency of the data itself. There's also an understanding of the uses and limitations. These are essentially research databases with typically 6 to 9 month lags on them. So you're not going to use it for, say, a settlement process for accountable care organizations, because that might be done on a monthly or a quarterly basis. But you might be able to use it with 2 years worth of retrospective data using the ETG grouper example to provide an ACO with information on clinical practice patterns to help it improve its services and become more efficient. One of the things in terms of especially states like California that are starting out is there are huge opportunities now for linkage to other databases like health information exchanges, health benefit exchanges, public health databases. Most of the databases that have been created to date have been created in a de-identified fashion. So from a privacy perspective, all patient identifiers have been de-identified. That's great, except it doesn't allow you then to link to other databases. And so if we really want to truly affect the healthcare system and use data to do that, we believe that linking this with the clinical information in the health information exchanges is going to be critically important, because the payment information are in these administrative databases and the clinical data is over on the HIE side. And so being able to link those is going to be important. I'll skip the next bullet. It's sort of further down. And then ultimately, the data processing piece. Currently, my understanding your state is OSHPD is managing the data processing for all of your hospital discharge data. And so that's a decision that states make moving forward. Do they outsource that or do they insource that? And again, we have a myriad of, it's about 50-50 right now in terms of what states are doing, or maybe 60-40 are outsourcing and 40% insourcing. But that'll be a decision to be made. Some of the other challenges are the completeness of the population that's covered. In some states, it might be as little as 6 or 7 carriers might comprise 90 or 95% of your commercial marketplace, and maybe that's enough to do what you want to do. In other states, we have folks that are collecting data from 50, 60, 70, 80 carriers in order to get to that 95% level. So there are decisions that need to be made there. In terms of the collection and release standardization piece, this is important, and one of the things that I mentioned earlier we're spending a lot of time on is data collection standards, and we're working with national data standards management organizations, one on the pharmacy side called NCPDP, and one for claims and eligibility called ANSI X12. A lot of acronyms, I apologize. But the point being is, just like there are HIPAA transactions today for things like claims submittal and eligibility, we're moving towards a similar process for all payer claims claims, so that just like we all know that ICD-10 is coming to replace ICD-9 at a certain point in time, we'll also know that a new version of the APCD standards are coming. That allows the carriers time to react and prepare their systems. It allows the states time to prepare and react and adjust their systems. And it also provides a national forum for states to make changes to these databases without having to do it just by themselves and sort of off in a corner. So if I want to start collecting, say, race and ethnicity information or something, other type of data field, there's a public forum that's national that would allow you to have that conversation. Another major challenge we have are non-claim payment adjustments. What these are, when you think about a claim being submitted to an insurance company, there's a simple transaction. There's a charge, and then there's a payment made back, and there's a copay or coinsurance. But there are also other transactions that take place between carriers and providers on a daily basis. They might be settlements to a contract, so there might be a debit or credit flowing either way. There might be additional payments for medical management services. There might be payments for medical home services. Those are not currently captured, yet they're part of the overall cost of the healthcare system. So we're looking at ways in terms of the standards process as to how to capture that type of information moving forward. Likewise, we don't capture any sort of premium information or benefits information, and we know that benefits can have an impact in terms of utilization of services, and we also know that better understanding premium and things like medical loss are going to be more important moving forward. So there are things that these databases in their next iterations are going to need to capture in order to meet the needs of the health policy initiatives that are underway. Such as to be developed payment methodologies in the next bullet. We've talked about consistency among state databases. I think we're doing pretty well here, maybe 6 out of 10 stars in terms of trying to have general consistency, but we definitely have places for alignment, and that's where the standards come in. We've talked about the challenge for linkage, and really it's a huge opportunity. State revenue. Many of these databases were created prior to the national meltdown that happened financially. And so states now need to be thinking about this from an expenditure perspective in different ways. Colorado is an interesting model in that their state legislature promulgated rules and legislation stating to create this database, but didn't attach any funding to it. They've created a 501c3 nonprofit, and their job is to go find the funding for it. So very different model. Other states have assessments on payers or providers. Others use direct funds from general funds, and we know that general funds are nearly impossible to get in all states moving forward. And then finally, to finish off here, just federal engagement. I mentioned several federal partners as part of our technical panel, and we do believe that there will be more federal engagement. Folks like the CMS Innovation Center and others, we believe, will be more connected to us moving forward. But our focus right now has been primarily at the state-based level, working with the National Governors Association and National Association of Health Data Organizations to really focus on the state needs first and the federal strategy second. So with that concludes my presentation. I think we'll hold questions until after Jonah gives his presentation and go from there. So thank you for your time and attention. Greatly appreciated.
So we'll move to Jonah, who will kind of take us from the national level down to the unique sort of process we have going in California. And let me just clarify, we're very much in an exploratory phase, and the work that Jonah's doing is that very first step that Patrick described, which is the stakeholder engagement. Jonah will give a little bit more detail about the process, but at this point we're really just trying to figure out what various sectors in California feel about this, what they might use it for, and whether or not they would find it to be a practical solution to tracking healthcare costs and utilization. So, Jonah.
Thank you. Let me first thank the California Healthcare Foundation for convening this group and for inviting us to present to you all. I'm going to speak from the perspective of the contractor who's been brought on to help facilitate this program and do some feasibility assessment of an all-payer claims database in California. So I'm with Manat Health Solutions. We're a consulting firm that's based in San Francisco and Sacramento. And we were charged with a very explicit set of activities. And specifically, it's to make recommendations and assess the feasibility of creating an all-payer claims database service in California. There are many components to this, and you saw Patrick's roadmap, which described many of the components. What's really important in this sort of investigative process is to try to identify in a set of stakeholder interviews and the background research that has been supported by about a dozen of these APCDs in other states, is to try to understand for California and our very unique healthcare delivery system. We're a very highly delegated state. We have millions who are still in HMO capitated care arrangements, which has significant impact on what an all-payer claims database might be able to do, specifically because we have millions of individuals whose claims are paid not by the primary insurance company, but by IPAs and medical groups, which means that there's other sources of data that have to be used in order to make this usable. We also have between 6 and 7 million people who go to Kaiser. And Kaiser has a very different model of paying for their patients and facilitating those transactions. So a lot of unique aspects of California which make it interesting to consider what an all-payer claims database really means and can do here. The second thing is to consider is before we jump into let's create an all-payer claims database, we really need to understand what do we want to do with this. What does California, the state of California, and the stakeholders need an all-payer claims database to be able to do? Are we really interested in transparency from the perspective of a consumer so that consumers can make informed choices about healthcare? If that is the case, what kind of information needs to be presented to them so that they can actually make choices? During the entire interview process that we've had thus far, and we've talked to about 20 stakeholders, we've heard repeatedly that whatever an all-payer claims database might do in California, the information that is presented has to be accurate and it has to be actionable. So we can't have an APCD that simply has data, presents data, but doesn't really add value to consumer choice, purchaser choice, or other activities. So it has to add value, it has to be accurate, and it has to be actionable information. So that's part of what we're trying to do in our analysis, is to try to identify what services could provide the kind of actionable information to promote and provide value to the stakeholders. In addition to that, this is driving how an all-payer claims database would be governed. And so we're looking at models, and I'll show you in a moment what that means, how an APCD would be governed either in a state organization or in another kind of an organization like we heard in Colorado, which is sort of a nonprofit. We're also looking at the right engagement strategies to ensure that all the stakeholders have a voice in what an APCD might be able to do. We have to understand what the technical requirements of an all-payer claims database would look like to support the services, and then we have to understand financing. What's it going to cost to put into place, and what is it going to cost to maintain it on an ongoing basis? So our project kicked off in February with the California Healthcare Foundation funding, and in May we'll conclude with delivery of a roadmap which would describe what the stakeholders in California and have defined as of interest and might be able to lead towards an all-payer claims database being created in California. I mentioned these 4 areas. We're looking at identifying the services, policy and governments, the kind of data collection and data release, access and disclosure that we would have to in an all-payer claims database, the policies that would be needed. So these are all components of the focus areas that we're looking at in this roadmap. And as we do these interviews and we're collecting information, we're trying to specify which one of these domains and how an all-payer claims database would be created. There are a few basic services that many all-payer claims databases in the rest of the country have support. And I'm not going to go into these in detail because Patrick already demonstrated many of these to you. They tend to focus on things like quality, utilization, and cost. There are a couple of additional areas that are specific to California that might lend itself to an all-payer claims database here. For example, there are a number of voluntary data quality reporting initiatives in California. There's a pay-for-performance initiative that the Integrated Healthcare Association has supported for almost a decade. and that relies on both provider and carrier claims data to be used to assess quality scores. And so that requires data feeds from carriers and from providers. There's also something called CCHRI, which is a HEDIS data collection and quality reporting initiative. It's through the National NCQA reporting. That's been going on for almost 17 years. And again, that requires data feeds from carriers. There's something called CPPI, which is another data quality reporting initiative, which was attempting to provide quality measures on individual providers. More data, more carriers providing data. The point is that an all-payer claims database could be used to consolidate all of these requests. And instead of these one-off requests being made of providers and carriers to support these initiatives, an all-payer claims database could consolidate that so that one set of feeds is coming from providers and from carriers supporting these initiatives with their data needs. The other things we're looking at are, what is a role for claims data in risk adjustment in a health benefit exchange? We know that by 2014, all exchanges for health insurance under the federal health reform law will have to risk adjust so that the premiums can be accurately adjusted for these either individual or small group plans that are being offered. Can claims data be used to help make that risk adjustment happen? That's a very important question. And another one, just leave it at that. This is a depiction of some of the voluntary initiatives that I mentioned. It doesn't describe the entire environment in California. For example, OSHPD is getting data under state mandate, discharge data from hospitals, and they're collecting and reporting it. But this depicts some of the voluntary initiatives that I referenced earlier in the current environment. And as you can see from this, and you include other voluntary initiatives like CHART, which is data quality for hospitals, many data requests, all of them somewhat independent from each other, but they're often going to the same carriers, the same plans, the same providers. The opportunity for an all-payer claims database is to consolidate those so that instead of all these multiple feeds, one feed is going to them. And again, the question is, how does a health insurance exchange risk adjust? Is there a role for this kind of APCD to support it? In my previous life, I worked in health information exchange with the state government, and Cal eConnect was created under that program. Cal eConnect is a health information exchange in California, which is really focusing on clinical information for provider and clinical decision making. Is there a role for Cal eConnect in supporting the all-payer claims database? There may be, and we need to understand what that role might be. When it comes to issues of governance, there are a few potential options that could be considered in California, and these are examples of options in other states that have been categorized. Most states have gone down the path of having mandatory reporting requirements. So the dark blue shows you that of about 9 states or so that require by statute that carriers that meet certain thresholds deliver claims data to the state agency or agencies. So that's a mandated governance model whereby the administrator of an APCD actually lives within a state, either one agency or shared across multiple. There are then voluntary initiatives in Wisconsin and Washington. There's no mandate. They're not regulated by any statute specific to APCDs. But they have carrier participation. Many carriers are actually participating in these, including the Medicaid agencies in both of those states participate and provide data in a voluntary manner. And then there's this hybrid notion, Civic in Colorado, which was authorized and deemed by the state as a nonprofit to administer the APCD. There are requirements, mandates that carriers actually deliver data, but instead of delivering it to a state agency, it's delivering it to the nonprofit. So these are 3 models to consider for California, and 3 models we're testing when we're having our interview phase with the many stakeholders and trying to determine what might be most specific, most appropriate for California. And as many of the interviewees have been telling us, it really depends on what the all-payer claims database does and what activities it's going to support, which should determine how it's governed, which makes a lot of sense. There are policy and regulatory issues that we need to consider in APCD in California, obviously aligning with HIPAA and any disclosure and privacy and security policies. There's specific law in California that need to be understood and followed. The Confidentiality of Medical Information Act is one, but there are many others as well. And so part of our process is to surface those and identify what are the issues with each of the specific state laws and regulations. There's also issues around statutory authority and governing organization. In many of the state statutes, we've seen, for example, that the statute dictates the board composition or the advisory board composition of an all-payer claims database council oversight body. And in some cases, there's a statute that describes things like the levying of fines for noncompliance. So we need to try to better understand what California, what's appropriate for California. And if a nonprofit is going to be deemed, like in Colorado, to administer an APCD in California, who would the regulating organization be in California? What authority would they have? How would they relate to Health and Human Services Agency or the Department of Managed Healthcare, or CDI? So those are very important questions that we need to consider in this process. And then there are data collection and release policies and approaches that also have to be well understood and determined. Technical operations, again, not on the privacy side and policy, but there are things like data standards that are related to HIPAA that we need to be considerate of when determining how data will be sent from a carrier to an all-payer claims database. And then there are data release policies that need to be considered. One of the things we've heard from stakeholders thus far is it's very important to understand how the data are intended to be used, because it's very easy to misinterpret information when it's taken out of context. So data release policies are going to be informed, or should be informed, by stakeholder input, so that it's really well understood when data are released, and this isn't identified data. That's not being considered at this point. We're just talking about aggregated data. When those types of data are being released, what does that data actually represent? So that it's understood, and if any of this were to be published, it's understood what those data actually mean. And then there are funding and cost drivers that need to be considered in the California context. The funding cost drivers in California are significantly different. Well, the drivers are the same, but the cost implications in California are different because we're 38+ million people. The biggest all-payer claims database, I think, is 5.5 million that exists today. So we have we have to consider we have a gap. We have to consider what that means and how much it's going to cost. We also have to consider other parameters that will drive cost. The number of carrier feeds alone. I mentioned the delegated model in California. If we want complete data, we need to go to the medical groups that are paying claims. There are 300 delegated medical groups in California. That's a lot of data feeds, and that's going to drive cost. There are other issues around provider and identity management. We have 120,000 plus licensed physicians in California. So obviously it's going to be complicated to try to standardize on provider identifiers when data are coming in, if and when data are coming in, to connect those identifiers from all the different sources. There are other things as well. There are different analytics capabilities. We heard about ETG groupers. Those can be incredibly powerful in helping to understand episodes of care and stratify risk of populations. Also very expensive to implement and use on a database like this. So there are cost implications for the kind of analytics that are going to be used. And then Patrick touched on the funding sources. Some states haven't authorized any dollars for their APCDs. We have to consider in California what is going to fund an all-payer claims database. The Department of Managed Healthcare is currently funded by fees assessed on market share of carriers that it regulates. That's one option. There are other options like state-supported fees. Some states have taken a quarter-cent per claims transaction fee, and they are able to generate a few $1 million that way to support their health information exchanges and all-payer claims databases. So there are those kinds of fees that could be assessed. But there are also general fees that can be applied for data access and use. So if you're an employer, a self-insured employer, and you want to understand how your population is faring relative to other self-insured employers in terms of cost and utilization, so that you have some sense when you're negotiating with TPAs or with providers, there could be a charge to them to access the data and to be able to analyze how their network is doing compared to other similar kinds of networks to help inform negotiations, for example. So there are a whole host of ways that revenue could be conceived of and generated in an all-payer claims database, and others here: grants, Medicaid match dollars, federal dollars for Medicaid's participation, paying their share. Those need to be considered as opportunities and potential funding sources for California. So I'm gonna stop there, and I think we have some time for questions and answers.
Right, we absolutely do. And I think we have a roving microphone so that not only people here can hear those questions, but people participating in the webinar section can as well. And Danny, I think we've got a question in the back. Middle bit.
Joe Parra, Senate Republican Policy Office. I was going to ask a question of Patrick, but Jonah in his presentation kind of hit on an important point. Jonah alluded to the fact that a potential use for the California database might be for providers and/or plans to get a leg up in the contractual negotiation process. Question to Patrick. Has the information in the New Hampshire database been used for that purpose, and if so, to what extent? And do you have any indication of that's had an upward or downward effect on rates? Thank you.
Yeah, that was probably the first question. Well, it's the first question I got yesterday when I spoke downtown in San Francisco. The answer is yes, because the data has been made available at both the payer and the provider level. We are seeing both payers and providers using it as part of as a rate negotiation tool. To answer the second part of your question, there has been no evidence of any increase in overall medical trend, and there's been no evidence of any decrease. It has stayed flat. And in fact, California Health Foundation funded a study that was done. Both qualitative and quantitative measures were looked at to address that. What we have seen are certain procedures and have changed at a carrier level because they've been able to go back in and renegotiate. And we've seen in one particular serious outlier provider facility, one carrier made significant strides in reducing its overall cost. Where those will pop up in the system somewhere else, I'm not sure yet, but that's typically what happens when you squeeze the balloon. But yes, it has started. There are no other states besides ours right now that are releasing that level of data in the way that we're doing it, with the exception of Maine, but it's a little bit harder to get to, but it is being done in Maine as well.
And let me just follow up on that. So the study that Patrick referenced, which you can get on the CHCF database, but I can send it to you as well, we actually did look at New Hampshire and the effect, and what we were trying to figure out, there were some people who speculated that once you made rates transparent and everyone had them, that some argued rates would go down. Other people argued, no, actually they'll go up, because you have hospitals that thought they were getting a good rate until they saw the hospital down the street's rate, and suddenly they would demand more. But actually what this study found was that the market concentration issues and market power issues sort of trumped transparency. And so that we didn't actually see either the trend going up, as Patrick mentioned, or going down, or even a reduction in variation, kind of people moving toward the mean. But in the example that Patrick gave of this one very high-cost hospital in New Hampshire, it was almost the fact that the rates were transparent and it was on the front page how expensive this hospital was, that suddenly the hospital backed down a little bit in terms of its rate demand. So there is some power to transparency in the media, and can help, I think, some people moderate their demands a little bit because of that. But that's one anecdotal example. It's hard to say that transparency would actually have a huge effect here in California. It would probably still be market strength that would govern rates.
Yeah, and I would echo the market component for us is huge. We have basically 4 payers 3 really, if you look at it, and 26 hospitals with 2 communities that have more than 1 hospital. So there's not a lot of competition going on, and those factors trumped, to use Mary Beth's term, we think the transparency information. But the carriers and providers do continue to use this data on a daily basis in terms of their negotiation efforts.
You know, many of the interviews we've had, again, they keep speaking to this notion of being actionable, and a few stakeholders have said, you know, the opportunity for consumers to be empowered because they have better information about quality and about cost is significant. But when we drill down into it a little bit, getting back to the actionable component, consumers don't have a lot of choice in many respects with respect to the facilities they might be able to go to, or even their physicians. There are a few cases where that might be not, where they may actually have some choice. And it typically tends to be, from these interviews at least, and I think there's some truth to this, focused on these acute episodes where you actually are going to have a knee replacement surgery. And you may actually have a choice as to whether or not you're going to go to 1 of 3 hospitals. And so if you can have information that's good enough about what your out-of-pocket costs are going to be going to hospital A versus B or C, you might actually make a choice based on that. But what we've heard repeatedly is that those kinds of choices tend to be smaller and smaller. They're not about the whole range of services a consumer might get. They're probably based on these acute episodes, and they're probably kind of specific to a subset of acute episodes.
It's also largely driven based upon benefit design, to sort of follow up on Jonah's comments. So if I'm in a plan that doesn't have high deductibles or an incentive for me fiscally to shop for services, if you will, then I'm probably not going to do so unless I'm incredibly consumer focused and interested in cost and quality, et cetera. We are one of the 2nd or 3rd, depending upon the year, highest insurance premium states in the country, and we are seeing increases in the number of these high deductible plans being sold in our marketplace, and that's why the insurance department developed that consumer product, was in anticipation of what we were going to be seeing in the small group markets primarily. So benefit design plays a huge role here.
Hi, Brian Young from Cali Connect. I'd like to know if any of the databases are currently sustainable, self-sustainable, and could you describe the business model for 1 or 2 of the most successful ones?
So fiscal sustainability, I assume, is the question?
Yes.
Yes. Yes. I guess I have to answer that in a couple different ways. You could look at Vermont, for instance. So Vermont has a claims assessment, and it's a 7-year assessment by the legislature, and it was designed originally to pay for HIT incentives before the federal incentives were created, as well as to pay for their health information exchange. And as part of the Vermont Blueprint, which is their plan for healthcare reform, they've now rolled the APCD into that. And so they have a 7-year sustainability plan under that particular model to fund that. And so it's $35 million over 7 years for those 3 particular services. There's 1 or 2 other things it pays for as well, but that's primarily it. States like our own are basically at this point tied to both Medicaid match money as well as our general funds. We believe that our state is sustainable because we made a conscious effort very early on to produce a lot very quickly and make this part of the everyday lives of policymakers and others. And I think that was a good strategy, and it's kept the system since 2005 funded. And we're in our budget process now. It's also inexpensive for us. For us, it's about $300,000 a year to maintain the state's portion of it. So an $11+ billion budget, so it's not big. Other states like Maine, I think, is sustainable in the sense that, again, they've spread it through an assessment across providers and payers. They're also using fees for data release. And I think that there are, again, not a huge portion of their revenues, but it's enough that, pays for an FTE or two to help, in terms of the management portion. But I think moving forward, it's untested. For some of the newer states like a Tennessee or a Minnesota, I think will probably be fine because, again, it's wrapped into their overall strategy for healthcare reform, and it's a very specific component of their health reform strategy. But newer states coming on, or who may have just come on recently, are going to struggle, I think, for some period of time with that sustainability question. I think Jonah's list on the prior slide is a really good list. It expands upon what is currently being done by states in a couple of different areas, and things that states have talked about but nobody's had to go to yet because they've been able to live on general funds or these other sources. So we are in a different age now than we were 5 years ago when some of these other databases got started fiscally, and I think Colorado was sort of the first real test of that in the way that they set up their model. So a long answer, but it's sort of watch and wait in some states. And I think they'll need to produce. If you're not producing, as Jonah said, actionable information, I think in a timely fashion, and these databases can get going within 6, 8, 12 months from the time you say go, you can actually start looking at data. We've seen that in states as large as Minnesota or Tennessee, which again are smaller than yours, but again, still fairly significant.
Hi, Armand Feliciano, CMA Policy. I just want to get a clarification. It's called All-Payer Database, but I think I've heard you twice now say provider stuff. So I just want to get a clarification in that. Do you intend to actually collect just claims data, or do you actually intend to collect clinical data as well? Number two, is there any data from other states where it actually shows that cost has gone down because of an all-payer database? And finally, number three, what's sort of your ballpark figure on funding something like this in California?
Okay. I will start, and I'm going to let Jonah take that last one. How's that? Does that work for you, Jonah? Okay. So we are collecting claims data. We are not collecting clinical data. We expect the clinical data to be coming from the health information exchanges. We know that some carriers are working with national labs like LabCorp or Quest, and they're actually getting test result information. But none of the states are pulling that information from the carriers. It's only claims data coming from the providers. When I mention provider, we're building in many states provider databases that are composites of all the provider feeds that come from the carriers, so that you can actually come up with a slide that shows hospital A versus hospital B. So that's the provider database that was referenced. It's not a clinical database. It's only claims data. In terms of any states that can show that costs have gone down, no. I don't know of any state in the country where costs have gone down in the last 35 years. So these databases to date have not done that. They are an augmentation of other databases that have existed. Medicaid has had databases of their own. Medicare has had databases. Hospitals have had databases, discharge data. This is just yet another database that expands it with dental, with outpatient, with pharmacy, and other types of data to help us complete the picture. But it's not. It's again, not going to be the full picture yet. There's no one perfect database. So no, nobody has proven that costs have gone down. But again, no state that we know of, and again, New Hampshire is the only one that's had a formal evaluation done, has shown that costs have increased because of this. They've stayed exactly on the same trend. But these are very early on. Tennessee has just now started to analyze its data after about 18 months of development. Minnesota is just starting to analyze their data. Very few states have actually been running up long enough to actually produce volumes of data to start showing to the public at this point. We're in a new age here.
So just to clarify, so Armand, he was speaking for New Hampshire, and there's no intent at this point to create an APCD that I'm aware of. What the wisdom of the California Healthcare Foundation is to determine whether or not this is feasible and what it might do. So I just want to make sure that's really clear, because when you were asking the question, it sounded like you were asking as if this were a done deal, which, to my knowledge, it's not.
Okay, I misinterpreted your question. That was it. Sorry.
But I just want to clarify for others in the room.
And then the ballpark question.
Yeah, so
I'll put that one to Jonah.
A couple of other things. So one is in terms of administrative only. The notion was, yes, it's administrative only, it's claims data, but providers right now are paying claims. These are the IPAs and medical groups that are delegated by HMOs and to pay some HMO and PPO claims as well. So again, that's not clinical, it's administrative data, but those data are held and those claims are paid by the IPAs and medical groups, which is why we're saying providers may be one of the participants in a theoretical future California all-payer claims database. In a couple of interviews, have I made that clear?
I like that. Theoretical future claims database.
In a couple of interviews, we've heard many times in a couple of interviews that having lab results would be incredibly helpful because of all the quality reporting that is associated with it, especially on heart disease and diabetes. And to be able to use those lab results in combination with administrative data would be very powerful. So that is something, obviously, that has been signaled by some stakeholders as critical and important. So as soon as you get clinical data into the mix, you start to think about the implications of patient privacy, obviously. And so that, again, has to be considered in the context of what it means in California for an all-payer claims database. In terms of overall costs, we don't know yet. And I'm not in a position to make an estimate at this point. But part of this process is to try to come up with some ranges of what it might cost in California without actually having any kind of a formal request for proposal from vendors. And we're taking data that we can get from as much as we can from other states, and we're building some assumptions about what it might take to cost in California so that we can make a better decision, better informed decision for what it might be in California.
If I could just make one comment on the lab data. One of the reasons why other states have not brought that down from the payers, in addition to the privacy issues, is that it's not complete. Because they're only collecting it primarily from the national labs, and many hospitals have labs, and there's outpatient labs, et cetera, and carriers do not consistently collect that data. And so the feeling is if it's not a consistently collected data element across the carriers, that it shouldn't be in the database. And that's been sort of a general philosophy by the states who have developed these databases. So that's one additional reason why that clinical information has not been brought down.
And I just want to reinforce what Jonah said about kind of the scope of this project is really first to figure out what would be the benefit of doing this? What questions do we need to answer, and what would be the impact of having an answer to that question? And does that potentially justify the cost of doing this? And one of the huge variables in terms of driving what it would cost is that kind of data feed question. So if we can get 80% of the people in California that are commercially insured by pulling in the claims from 8 carriers, then maybe we only want to do those 8 carriers. We want to set a threshold. And many other states have set thresholds. So you don't go after every last payer in a state that may have a few members, but we go after where we can get a big return. Even on the IPAs, we potentially can get 80% of the IPA claims we need from dealing, with the 20% of the IPAs. So in many cases, I think we're going to want to look at what is it we're trying to answer, and what's the minimum amount we need to do in order to get an answer to that question, so this doesn't become so unwieldy that it would, it could never really be done. So those are really important questions. Thanks, Armand.
Yep.
Andrea Rosen, California Department of Insurance, and my questions go to integrity of the claims data. And I think Jonah referred to it as accuracy. So let's just assume for the moment perhaps integrity and accuracy can be the same thing. In the business of enforcing claims handling statutes in California, which is on the insurance side, which is in full disclosure where I'm coming from, there's there could be a lot of question about the integrity of the data that you get from commercial insurers. And I'm wondering kind of how you control for that. For example, when you use the term cost, are you including both what the payer and the patient and or insured, whatever member, is paying, because if so, that's a different definition of cost than what the payer pays.
Absolutely.
And how are you taking into account in your other databases such things as, I'm sure you're familiar that health insurers have very robust recovery operations. And under California state law, for example, an insurer is entitled to go back up to 365 days after the date of payment to adjust that claim. It's true that there are a huge number of claims that are reworked, re-adjudicated, reprocessed. So I'm terribly curious about the level of integrity and accuracy of your data, because you know, like everybody else, the quality of the question that you can answer at the back end is heavily dependent on the quality of the data up front.
Right. It's a great question. Having worked for a payer in the 90s and in charge of data warehousing for 16 different health plans, these were questions that were very real to me at that point and are still real today, as you say. I think a lot of it has to do with the quality of the vendor or the data processor, first of all, in terms of, you know, who's been chosen to actually do that work and how well they understand it. I think a lot of it has to do with the relationships between the data processor and the payer itself, and understanding the differences in the way payers process claims. Because even within a payer, they may have multiple transaction systems. You know, one may capture 4 ICD-9 codes and one may capture 3, and they check out the other 3 that were submitted on the claim. And so all those nuances, if you will, do need to be understood, both during the processing component as well as the people who are analyzing the data. And we've been very fortunate in the states that we've seen so far, where oftentimes, and even in our own institute at our university, we have 3 analysts who come from the payer. They used to work for payers, and so they understand payer data. And it's why one of the slides I had in the very beginning was knock on the door of the payers first, and they have to be at the table. We also use monetary disincentives. So if payers aren't complying either with timeliness of submission or quality of submission, there's actually fines in statute in many of the states, and that's been employed, unfortunately. It's not something that anybody wants to do, but it has been done, and that has gone back into funding, you know, for these efforts. But it's a question of constant vigilance, to be perfectly honest, and having people who are processing and analyzing the data that have direct lines of communication with the payer community. In terms of the question of retrospective processing, a couple different issues. One, there's only one state that's actually capturing denied claims, and I think they're now sort of regretting that they did that in some respects. Most folks are waiting for the claim to come through, and then as the claims are collected monthly, they're processed on a quarterly basis, released quarterly, and then there's an update done that's retrospective. So it goes back and picks up that information over a series of years. And so if you do have retrospective, and we know claims get adjusted all the time, right? So those claims would be picked up in the next release of the collection and release process of the data. So I don't know if that answered all of your questions, but it is something of constant vigilance, and it's like collecting any type of data. There need to be data quality checks and processes in place. We now have a contract with our insurance department to actually perform data quality checks on our data processor as a secondary check because of some of the things that we found through the processor, and then that gets fed back in a quality improvement loop to the processor. And so we've taken an extra step and an extra $70,000 a year or so to basically make sure that data is of high quality. And then my final comment, I guess, would be on release of the data. So how does it get released? Who has access to it? What are their qualifications, you know, as a data analyst or as a data reporting entity to be able to actually handle that data? And how do you have those discussions? And typically there's an institutional review board type of a process or governance process set up in states around release. So those are some of the ways that states are handling it, but it's not, there's no perfect data set anywhere in the world, I would argue, from a quality perspective, especially with claims. So, but these nuances do exist. We know they exist, and really forming those tight relationships with payers, I would argue, is the best way to be there. And I think if AHIP is in the room or any representatives, they would probably say the same thing, and we've had conversations with them.
So we have a couple of more questions. Let me just remind everyone that we have an evaluation form you might want to fill in while you're thinking of your next question. So Danny, we have one here and then one in the back as well. Oh, got it. Ron, thank you.
Hi, I'm Ron Spingarn with the Office of Statewide Health Planning and Development, and Patrick called us OSHPOD a few times, for those of you who don't know the acronym.
Sorry.
Everybody knows the acronym.
We all know you.
I'm bad with acronyms.
I have a two-part question, I think, one for Patrick and one for Jonah, around policy framework in terms of quality issues and cost issues. So, Patrick, you said you were going to circle back with how this has been used to impact quality, or how quality information has been incorporated with claims databases. I was wondering if you could touch on that a bit. And then regarding cost issues, Jonah, I'm not sure whether your paper is going to address this, but given that the apples or the relative sizes of the states vary, and California is an awfully big one,
Yes.
Will you be looking at cost drivers, for example, pharmaceutical costs, and approaching this in California as looking at what claims may be, instead of an all-payer claims data, pharmaceutical cost pair or pharmaceutical claims data, as potentially, that being a high cost driver, and just taking that bite of the apple as opposed to, across the board, or breaking down somehow the policy issues that the approach in California could take, maybe a little bit more granularly than some of the other states have.
So I guess to address the quality question, we'd first have to define quality, which could probably take several days, depending upon our definition. I think the way states have been approaching it to date has been fairly rudimentary in terms of looking at it more as things like preventive services in populations. Have they, looking at differences of prevalence rates between populations. One of the projects that we have underway right now with a consultant that does a lot of work with AHRQ is taking a look at the standard measures that have been developed, HEDIS measures, AQA measures, et cetera, and comparing that against the data collection standards that have been created to determine which ones we believe can be used and can't be used. And this project was spurred by one state's Accountable Care Organization program, where they're looking for the evaluation measures that would be used and trying to, again, stick with standard quality metrics. We've also done some projects using ARC methodologies. One specifically looked at adverse drug events, and that was a quality improvement project focused on how health information technology, e-prescribing specifically, might be able to assist in reducing the number of inpatient admissions in that respect. So I would say most of the states have focused more on the utilization and cost, and to the insurance department's point, cost. We're collecting charges, we're collecting allowed amounts, member co-payments, and paid amounts in these databases. So when people say cost, it means different things to different people, but those are the four components that are being captured. So I would say that's sort of as much as I can comment right now on the quality side. And still fairly nascent. Most of the states have been looking more directly, I would say, at the utilization and the cost components at this point.
With respect to your question on the pharmacy data, this goes back to sort of the original top-level question that Mary Beth also reiterated, which is, what are the kinds of questions that we really want to answer? And if it's valuable enough that just having pharmacy data can help answer some really important questions, that might be a process and a first step that we want to pursue. And we've talked to PBMs, we've talked to a lot of people in this process. We talked to pharmacy benefit management companies, and they've indicated that they could actually, on behalf of their plans, because some of them, there aren't that many PBMs, first of all, and they could potentially, on behalf of their plans, provide this data for all of their California-based plans to some sort of a service like an all-payer pharmacy claims database and help us answer some important questions. So that's certainly possible.
Yeah, we probably have
Hi,
time for
so Cynthia Robinson, Department of Healthcare Services.
So what's your name?
Cynthia Robinson.
Great.
And what I was wondering was if you have any projects that looked at cost shifts to the public sector. I know you're gathering information from carriers and payers,
Right.
but some of the questions that come up is, well, if employers are cutting back on benefits or eligibility, and to what extent are people popping up? Maybe it's not in the fully insured population, but to what extent are people popping up in ER rooms or children's charity hospitals or counties' medically indigent programs? It's been talked about a lot in healthcare reform. The hidden
Right.
tax. And do you have any projects that speak to that?
I'm trying to think of any states that have any specific projects. I mean, the point you raised, it's been raised and been discussed. There's been efforts looking at cost shifting from, say, Medicaid reimbursement to the commercial population in terms of cost shifting from that direction, but that's a different question than one you asked. I don't know of anything right now that anybody has looked at. Oregon and New Hampshire are about to begin projects looking at the dual eligible populations within Medicaid, and also some economic forecasting around how those populations may grow over time and what the impact to state budgets might look like in those populations. But that's more of a demographic question, I think, than sort of a shifting question, as you just asked. So I don't know of anybody that's doing exactly what you're saying at this point in time. Could these databases do that? I would say yes. I mean, I think they could answer those questions.
And let me just quickly add, when we keep saying all-payer database, all is something that we really need to define more closely, because certainly we're talking about potentially commercial carriers and hopefully Medi-Cal data as well. Medicare data is much harder to come by, and that's a huge percentage of the claims going on in California. There are a couple of states who've been successful in getting Medicare data incorporated as well, but that's one of the questions we need to answer. Do we mean all commercial or all public and private payers?
Right. And TRICARE, I mean, if you look at your military population in the southern part of the state, the one I think of in your state, that would be huge. Hawaii, 10% of their population is military, so they would want to get TRICARE data, for example, if they're looking at all payer. So there's it's not just commercial Medicaid and Medicare either. There are other federal programs. Indian Health Service is actually one component that Oregon is planning to collect.
Yes.
Hi, Anna Davis, UCLA Center for Health Policy Research. I was wondering who bears the burden of assembling the uniform data set. Does the agency that's creating the all-payer claims database undertake that effort, or do the payers have to submit data in a uniform format?
Well, one of the things I think that's great about California not being the first one to the table, one of the rare times we're following other states, is the fact that there is a growing interest in having a uniform data set. And the national health plans are very interested in doing that because they need to submit to that standard. So instead of having them send generic claim files and someone try and clean them up, they have to send us a file that's in a particular standard. And I definitely think California would want to pursue that approach. Seems to be the most successful of what's happened in other states.
Right. Essentially, there's a data processing clearinghouse of some sort. Either it's a commercial entity or it's a state itself that's doing that work, and they develop the one-on-one relationships with the payers and manage that feed process, much like the OSHPD folks would be working with the hospitals. And there's different technical ways that they move the data and de-identify the data. We could talk about that offline if you wanted to, but yes, it's centralized.
We have actually two more, and I think that'll take us to our time.
I have two quick questions. One is, how many of the states have Medicaid and Medicare participating? And what's the impact of that on the data? Like, is it richer? I mean, how big is the percentage of Medicaid in those states? My other question is, if you don't mind breaking it down entirely. What exactly is in the claims data that improves quality? Because, I mean, it's not associated with outcomes, I'm assuming. Is it just money? That's it.
Right. So I guess in terms of the quality point, again, I would say it depends upon how you're going to define it. I think most folks have been looking at it to date because there's limited clinical information in here. We're talking about, and that gets to your first question, so maybe I'll go back there. So what are we collecting? We're collecting basically all data that's transmitted off of what are called an 837, which is a claim that's submitted from a provider into a payer, and it could be everything from date of birth and the member identification number to procedure code information, diagnosis code information, place of service, type of service, and then the charge amount information. And then ultimately on the back end, after the carrier processes it, you get the member copayment information and the other payment amounts allowed and paid that I talked about before. So essentially what you would see on a claim form is what you will see in this database. And so to get to your second question around quality, I think most folks have been looking at it through things like the HEDIS measures, and states are running, you know, this data through. We have employer groups that are using it in that same way, and that's looking at quality in the sense of, you know, is enough of a certain service being rendered? So are enough females 45 to 54 getting a mammogram? You know, and so that's sort of the view of quality that's being, you know, generated out of a report such as that. But there are certainly other metrics of quality, such as the AQA measures, the adverse drug event piece that I mentioned a few minutes ago, that are also being addressed as well. I think there's a long way to go still in understanding exactly what the final contribution of these databases is going to be to quality and quality improvement. But I think if you asked a dozen people what quality is and how to measure it, you'd still get different answers, even though there are many standard quality measurement systems that have been developed, you know, nationally through both private and federal agencies. Does that help at all?
One addition I might make to that, also using for things like understanding variation. So why people in Palm Springs get MRIs at 6 times the rate of any other community in California. Right. Questions like that can be answered through this as well. And we have some of that information through the Dartmouth Atlas, but that's just the Medicare population. It's important to see how that differs for commercial and potentially Medi-Cal populations as well. So I think taking a broad definition of quality, looking at utilization, appropriateness, variation, are all sort of important questions that can be answered with this. Right. Mike. Lisa had a question?
Mike Cassis with Office of Statewide Health Planning and Development. Regarding the quality question you asked, absolutely. One of the things that we would look at, given the kind of data that we could get through a claims system, would be linking. Like we do now, we link our OSHPA data with death data and birth data, and that opens up a whole wealth of answers regarding quality questions. We can also take a look at readmission issues, and we can take a look at outpatient care, whether or not that's working, and people are keep staying out of the hospital or using outpatient care and ending up in the hospital. So there's a ton of quality questions that can be answered with this data.
Right. And also on the hospital discharge, you've got a present on admission code, and that will also be on the claims moving forward, and that will be another key data field that these databases will be collecting.
I think we've got the last question.
Last one, okay.
I'll make it quick. Lisa Chanson with the Senate Health Committee. It's pretty clear that there's a lot of things that we could do once we have the data. I was wondering if the report will sort of address the range of things that could be done with the data. And then secondly, if any other states are looking at using this data to do any type of rate review or rate regulation. Thank you.
So I would anticipate that the report would describe the many things that the APCD could do. What we're trying to do is we're trying to identify areas where there might be some consensus about what it should do, the kinds of questions that it could answer, and identify those. And there are some that seem to be emerging, and then those where there's not consensus, and try to identify whether or not there's some that's worth trying to get consensus around, or if it's something for a later date. So I imagine that we will be looking at that and trying to report on. And again, this is a report for the California Healthcare Foundation. It is trying to get to that question because that's one of the most fundamental, important questions that we're trying to get to.
In terms of the rate review and regulation, the short answer is not yet, but I think you will see that. I think what states are waiting for is what will the health benefit exchanges look like and what are the opportunities for integration of data. I think we could very easily add some fields to the eligibility files that we're getting on these databases that might include premium, might include benefits, some other things that could then help the insurance exchanges. But I don't think that there's been enough definition in the majority of the states about what the exchanges are actually going to look like and what the requirements are going to be able to do that. There has been some pushback from some of the carriers and sort of saying that you should not use these databases for rate review and regulation. And we've heard that loud and clear both in California as well as in other states. And so I don't know how that will play out ultimately, but I would imagine that there are, and I know that there are regulators in states that are trying to understand how this could be used in the future.
Are there any other states that are looking at, if they are looking at APCDs as a source of data for rate review or risk adjustment, leveraging any federal dollars that could be available for the exchange?
Not yet that I'm aware of. In terms of federal dollars, some states are using Medicaid dollars to help fund the systems, and there's one Beacon Health grant that's been granted that a state's using federal dollars. There have been some initial discussions with CMS, but I haven't seen anything formal. I don't know in your review, Jonah, if you've...
No, but we've heard two things in big concerns from carriers. One is they really don't want to see this being used in rate review and regulation, and two is if it is, they believe that any possibility that the cost associated with setting one of these up can contribute to the MLR and would basically go out the window. And so this then would be administrative costs they'd have to consider and wrap into their overall administrative costs, and which makes it harder for them to get behind and to support. Now, if it can be considered really a quality initiative and quality reporting, then it's something that I think the carriers would be much more open to participating in. If they could essentially wrap this cost of providing these data so that you can actually do quality reporting, and it can be considered part of the MLR. So.
And I think in the current state, it's fair to say that you really can't use these for what you just said, because we're not collecting the right data to help augment it. But could they in the future? I would argue yes, there's that possibility. But again, you're going to have to do the linkage piece, and that will create privacy questions.
Great. Well, thank you very much, and join me in thanking our panelists. Thanks.